I want to hand it over to Danielle Lloyd from America's Health Insurance Plans to present this year's measurement effort results. Danielle, take it away.
Thanks so much, Alice. I am really thrilled to be here today celebrating the anniversary of the LAN. I was privileged to participate in its launch at the White House and HHS 10 years ago, and it's just amazing what progress we've made in that time. So kudos to everybody who has contributed to that effort over the years. So now I'm super excited to announce the results of the 2025 APM measurement effort that tracks adoption of value-based care arrangements across the country and across all lines of business. So if we could go to the next slide, thank you. So first I want to acknowledge our partners. Over the past several years, CMS has led the effort through the HCPLAN with support from AHIP and the Blue Cross Blue Shield Association. For 2025, AHIP has taken the lead on the survey and the analytics, and thus I'm reporting out the results today. I've seen already a question in the Q&A, so I will note that our hope and expectation is that we will continue this work in 2026 with foundation funding and maintaining the partnership between AHIP, CMS, and the Blue Cross Blue Shield Association. I'd also like to acknowledge Catalyst for Payment Reform. They have helped with the back-end analytics since the inception of the survey. They've continued to work with us this year to ensure continuity across the survey, the results for a seamless transition. Next, I would like to thank all of the participants. We know it takes a lot of time and effort to respond, for which we are eternally grateful. And I know many of them are on here today to hear the results. So thank you. In terms of those who responded, there were a total of 58 health plans, 2 fee-for-service Medicaid states, and of course, CMS for original Medicare. This represents over 271 million individuals, or 87.5% of covered lives in the country. So very highly representative participation. If we move to the next slide, the 2025 National APM survey launched in July of this past year and concluded in October, with participants reporting retrospective data on actual dollars paid to providers in calendar year 2024 or the most recent 12-month period for which data was available. AHIP followed the same methodology and guidance that's been used in past efforts, but we did shorten the survey given the compressed timeline. Specifically, we removed 2 qualitative questions and the question that measured the proportion of lives covered in alternative payment models, or APMs. We have continued to categorize based on the HCPLAN APM framework that you see here. Just a quick refresher in case you don't have this memorized. Category 1 is fee-for-service with no link to quality. Category 2 is fee-for-service with a link to quality. Category 3 are APMs built on a fee-for-service architecture, and Category 4 is population-based payments. I'm going to mention those a lot as we go. But we also depict the data based on each line of business, as well as aggregated across all lines of business. So on to the results here. So focusing on first on the all lines of business there on the left-hand side of your screen, you can see that 44.9% of healthcare payments were tied to APMs that hold providers accountable for both quality and cost. So that's categories 3 and 4 in 2024. When you stay on that cylinder, looking specifically at the downside risk model, so category 3B and up, it's 28.7% of healthcare payments. If we continue kind of looking right across the slide at each line of business, you'll see that roughly 40% of commercial, 60% of Medicare Advantage, 43% of Medicaid, and 44% of original Medicare payments were in some form of alternative payment models. We go to the next slide. Just thinking about this across time, we wanted to show you all some of the trends. So when you think about 2023 to 2024, payments were generally stable. Payments in category 3 and 4 had a modest decrease of 0.3%. But when you look at the downside risk model, so 3B and up, it increased 0.2%. So a little bit down, a little bit up. Of note, though, of a couple of the categories that moved more, original Medicare saw a 2.3% percentage point growth in 4A, that's the condition-specific population-based payments, and Medicare Advantage saw 5.9 percentage point growth in 4C, so that's integrated finance and delivery systems. If you move to the next slide, we also captured health plan perspectives on future trends. So this is where we have the qualitative results. As you can see here, 70% of the respondents, so of the health plans responding, expect APM activity to increase over the next 24 months, citing health plan interests and readiness, provider readiness, and health plans' ability to operationalize such models as key facilitators. If you move to the next slide, in addition, 55% of those respondents believe the category that will grow the most in the future is 3B. So that's the shared risk / procedure-based episode payments. And that's been pretty consistent across the years, across the surveys. So there's a lot more detail that we don't have time to get into in this short amount of time today. If you'd like to see more of the graphics or the methodology report, please do visit the AHIP website under resources, and we give you the link there. So next, I'm going to moderate the next panel of experts in the field. Our panelists are going to offer insights into some of the trends that they're seeing across these market segments, share some success stories, discuss barriers and facilitators, and consider what is, what future success looks like. So I am lucky to be joined here today by first Kristie Spencer, who's Vice President of Provider Partnerships with Elevance Health. Also, Dr. Edie Calamia, who's the Chief Medical Officer for AmeriHealth Caritas, and Dr. Ali Khan, who's Chief Medical Officer for Medicare with Aetna, which is a CVS company. So with that, let's go ahead and jump into some questions. So thanks so much for you all for you all to be here today. Greatly appreciate you all sharing your insights. But we wanted to start with a little bit of just sort of broad trends. What are you seeing across 2024, 2025 in terms of participation in the value-based arrangements or any other sort of major factors that you've seen? And I always like to start off with the positive. So maybe highlight some recent success stories. So let's go ahead and start with Kristie on this one.
Great. Thanks. It's a pleasure to be here with you today. Across 2024 and 2025, we really saw 3 reinforcing trends at Elevance. The first is that value-based care is working. At Elevance, this isn't a pilot, it's how we operate. Providers in value-based arrangements are consistently outperforming their non-value-based peers across preventive care, chronic disease. We're seeing double-digit improvements in areas like colorectal cancer screening, diabetes care, blood pressure control, and we're continuing to see lower per member per month costs. So all very positive successes that we're seeing. The second trend we're seeing is that participation continues to broaden. So just as you were going through the results, we're seeing that as well. But we do see that participation is uneven across different risk levels. And what I mean by that is experience of providers really mattered. So we saw that providers that have stronger infrastructure really progressed into advanced models more readily, while others wanted clearer, more staged entry points. The third trend that we saw is that providers are shifting from this mentality of signing yet another contract to really seeking true practical enablement at the practice level. So what feels like or looks like it could be a plateau, we really see it as being a transition where providers are asking for simpler models, better alignment, and deeper operational partnership. And so these trends have really driven our evolution at Elevance to differentiated pathways with staged risk and stronger support along that pathway. One where incentives, engagement, and connected data can really work together to enable value-based care that's sustainable and scalable.
Thanks. Edie, why don't you go next, and then we'll have Ali follow after that.
Sure. So I think, Kristie outlined very well. We are seeing very similar types of trends, definitely a heightening of the sophistication of our partners in practice, certainly a readiness to ingest and share data across different types of providers, which I don't think we saw that level of maturity, previous to the last few years, where folks really are, again, embracing EMRs. We see more EMR usage, and therefore that exchange of data becomes a little bit easier. I think Chris put it well in that, we're seeing more of an openness to practice transformation, where there is perhaps a little bit less sophistication. There's more of an openness for practice transformation and how, as she said, alignment, which I think is really huge. We're seeing that willingness to, to meet, to come into the practices, but to really align with other payers as well, so that they're not deviating from that course of their day. And as a provider, certainly I remember having, kind of several value-based contracts, and, it's difficult if, one person kind of, one group kind of wants you to do one thing and one is having you do another. And so that alignment, we're hearing a lot of feedback that becomes super important, to be able to kind of, just see their patient and focus on their patient. And I would say too, what we're hearing is that as we're thinking about reducing provider burden, where we talked about, reduction in prior authorization and other areas that I know AHIP is working on, this becomes really part of that incentive, right? Is that we're reducing the burden in one area so the providers have that time to focus on that quality and aligning those incentives. And so I think that coupling together becomes very important. What we're seeing a lot of is different types of providers having a willingness to get into value-based contracting, which I don't think we saw, again, as much of. Years ago, FQHCs were not in this space. We certainly are seeing a willingness. Our health plan happens to serve mostly Medicaid members, and so many of our members travel through FQHCs. We're seeing a sophistication there that I think is really important, and a level and a willingness to align those incentives. We also are seeing, their counterparts, they're outperforming their counterparts who don't have those incentives aligned. And I think that's really critical and great, as we look at these longitudinally, is this the right investment? We're getting better levels of care in those arrangements. Well, then certainly we know that's something we want to double down on. And lastly, we talked about kind of some of the successes. I think what we're seeing is a willingness for other types of providers. Even, we're looking at contracting with nursing facilities, other facilities that, again, we're not in that traditional type of value-based contracting arrangements, have a willingness to come and talk to us about, the quality initiatives that they have going on, and could that be put into a value-based contract? And I think that's really critical, is that, again, that evolution where, other folks who have equally as important in the healthcare continuum really have that willingness to look at value-based contracting as well. Ali?
Yeah, Danielle, thanks so much for having us from the Aetna perspective. Edie could probably give the panel for me from an Aetna perspective, but I'll dig in. You asked for good news, and so what I would say, I think, from the good news is I agree with what both Kristie and Dr. Calamia said in that sense. Our value-based care actors continue to outperform the folks who are in our traditional networks, right? Like over and over again, from a quality perspective, from a cost perspective, when we think about the work, the crucial work, particularly in Medicare and in dual eligibles, which I serve, of clinically stabilizing people at the last mile. That is the work that our value-based care partners, particularly our folks who are in category 4, are doing over and over again. And that, I think, what we see, the 23 and 24 data, I think Danielle is really interesting. I think what will be really interesting to come back in a year and look at the 25 data, right? Because I think all of our lived experience here can tell us that that was a fast break kind of year in terms of what we saw. I would say that the growth opportunities that were huge, we saw a lot, especially value-based care actors, enter the fray. ranging from, maternity and postpartum care all the way through to end of life and everything sort of in between, with a real willingness to put that work at risk and sort of say, how do we get the work of, crossing the T's and dotting the I's to get great care management done for those players, has been a nice sort of development to see. I would also say that while 25 in particular was probably a year of transition for a lot of our purpose-built actors in value-based care and full risk value-based care, from a stepping back standpoint, we also saw a number of systems step up, right? Cleveland Clinic made a lot of news over the last couple of weeks at JP Morgan, talking about how with us and with Humana and others, they are really leaning in on saying, hey, we want to do a lot of exciting work in full risk and Medicare Advantage, which is not something that we are hearing historically from health systems, but we're hearing more and more from across the spectrum. I think that's been quite gratifying. And I think, Danielle, from the point of saying, what are we doing to sort of meet the moment, right? And how have we adjusted? We've spent a lot of time in really thinking about enablement from a care model approach, right? What are we doing holistically as a plan? We do not deliver care, right? But whether we're dealing with our own assets inside of CVS Health and healthcare delivery, or whether we are working with, provider groups across the country, how are we thinking about not only meeting commitments from AHIP around, easing prior authorizations when that makes sense, but really thinking about how we're using the levers of utilization management, care management, and medical management to actually drive making the process easier for folks for whom we are partnering in risk, right? And essentially, instead of sort of kind of handing somebody risk, dusting our big hands off and saying, set it or forget it, how are we actually enabling them to succeed? We are spending a ton of time on, refining and really getting precise our attribution hierarchies to make sure that we don't let people fall through the cracks and end up in 2 or 3 models. We are spending a ton of time on saying, instead of partnering with systems or partners who are, targeting a 30 or 40% engagement rate on a population, what would it take for us to get above an F, right? To get to 60 or 70%, and what are we as a plan doing using assets like a Signify Health or like other players that we work with to actually drive that real-time trust building to get people into these models? So from that perspective, I think that's the good news, where this moment in the last 18 months in particular has inspired a ton of creativity of actual partnerships as opposed to partnerships on paper.
Great. So, you talked a little bit about those sorts of supports, right? And that can be one factor in the success of particular providers in terms of value-based arrangements. What are some of the other things, the other levers and the other factors? So basically, what are the headwinds and the tailwinds that you think really impact success? And with this, maybe Edie, you can start that one.
Sure. Tailwinds, headwinds, there is always kind of a lot going on around this space, right? And I think when I think about the headwinds, there is always the enhancements that are happening in technology certainly could be a tailwind, but it also is a headwind because we know that everybody's not there yet, right? So that exchange of data and the ability to kind of seamlessly, give providers data that is actionable and that's happening in the moment, that's been a challenge since, I will say I've been doing this almost 20 years now. And in our original value-based contracts, we were coming in with data sometimes that was needed to be dusted off. And so providers, initial reaction was, I took care of that gap in care, or this was done already. And so that real-time actionable data is always a headwind when you're not, when you don't have that level of trust. I think building that level of trust with the provider to say, I'm bringing this to you because it's valuable, it's going to enhance your care to the patient. As docs, we want to give the best care, right? We want to make sure that they're coming to us, they trust us, and that, we're able to really give them that level of service. And so when you're able to show a doc, hey, you know what? This is something that maybe, was a diagnosis a person had previously that they don't have now with that data. It really can be very eye-opening. Again, making it as simple as possible because we know our docs are overwhelmed and our providers have a lot going on, especially when they're treating, Medicaid members, which are, can be particularly challenging. They have a lot of different things happening in their lives. And so we know they're oftentimes addressing much more than just physical challenges that are going on with members. And so again, one of the biggest, I think, if you want to call it headwind and a tailwind, is that technology and how you pull the technology component into this. We're talking about tech enabled. Our docs are getting there, but not everybody's there. Not everybody's even on AHRs in our space. And so, how do you get them, that data in a way that doesn't, kind of mess with the flow of their practice, but then really brings them such value that they see that, hey, this is not just bringing extra dollars to them, but really allowing them to give better care to the patients. And I think that's really what speaks to our provider community. As Dr. Khan just said, listen, we're seeing a lot more, thank goodness, a lot more of our hospital systems and other systems wanting, again, to drive this value-based care. We didn't see that before. So I think that's a great, headwind, but, a great tailwind. But, one of the headwinds is when the provider community is not necessarily always aligned exactly with with where we want our incentives to be. And so kind of pulling that on board and getting those systems on board, I think is really critical because we need to align those incentives. I think
Kristie,
in general, oh, I'm sorry. I was going to say, I just think in general, it's really all about the partnership, right? It's really about, that partnership with the provider, gaining that trust. And then I think we'll see a lot less in the way of tailwinds.
Kristie.
I'll just really build off of what both Dr. Khan and Dr. Calamia have said. I think success really in value-based care really centers around we have to enable providers. This is a partnership that's coming together. This isn't put a contract in place and then the provider walks away. This is really about how do we enable that provider with the right data, the right tools, and the right incentives that are aligned and supporting them along the way. The headwinds within the industry are very real. And maybe talking from a little bit more of a macro perspective, we continue to see escalating costs in hospitals, in pharmaceuticals, in health plan insurance. There's increasing uncertainty around coverage. We continue to have workforce pressures across all sectors, and then regulatory changes that just create an additional level of uncertainty. And so all of this makes it challenging to say, yeah, I'm going to go all in on taking risk on a population. But we each across the industry have a really critical role to play in improving healthcare affordability and outcomes. And value-based care continues to be a critical tool in driving affordability and outcomes. So as we continue to innovate, I do think that a lot of the pieces that we've called out are tailwinds. The way that we are leveraging data, that we're creating more connectivity. And I think this is a really critical point in the workflow of a provider where it is seamless in what they show up to do on a day in and day out basis, not a separate workflow. I think that's really critical that we get tighter on that. And I see us making good progress in that area. More timely, trusted data we're seeing good evidence of, as well as clear attribution. Providers have to know what the population is that they're accountable for, and we're making good strides on that as well. And then we've hinted at this already. Technology and AI are also playing a really pivotal role. Internally at Elevance, we're leveraging automation to reduce time on manual tasks so staff can focus more on members and on their experiences. And we're applying that same technology externally to support care providers, helping to reduce administrative burden, making it easier to see what care gaps are still open, and providing actionable insights to providers to support them on their value-based journey. And so the result then is that providers can spend less time on administrative work and more time with patients. So the bottom line here really is that success depends on us providing data that's actionable, preferably within the workflow of the provider, and that it's paired with a really well-designed incentive that impacts things that a clinician can actually impact within their day-to-day, and truly helping to enable providers in supporting the day-to-day.
Ali?
I think Dr. Calamia started us off really nicely in the context of the headwinds, Danielle, in talking about this, the general concept of mistrust, right? And so I think when you think about the natural relationship, always highs and lows between payer and provider, and then you take into account, sort of meteors in the past 18 months around, whether on the revenue side from a regulatory perspective, it'd be 28 for Medicare Advantage, but look at just general utilization trends, pharmacy spend, all sorts of things, right? There's been a natural desire from some folks to say like, hey, is it worth it, right? Like, why should I keep going with this if I haven't retooled my operations, if I haven't gone forward, if I haven't figured these things out? But I do think that's where the tailwinds that are really exciting are exactly what Kristie and Dr. Calamia pointed out. And I would say that it's around the pieces of saying, where are we seeing examples across the country? And I spend a fair amount of my time with this, traveling to see provider systems around the country in our network, where either the combination of critical mass through, new innovation center models, through the basic, eagerness for folks that continue year in and year out to continue to engage and enroll Medicare Advantage because of its general tenets, but also how technology and automation are showing us in our networks that people are really reaching in and developing models that are providing fantastic longitudinal care coordination, not to 3% of a population, but to 35 or 40% of a population, right? What we're seeing in the kind of work that's happening as we think about, systems that are using software as medical devices and thinking about how to do better and making sure people's depression meds are adjusted or people's heart failure meds are adjusted, so on and so forth. So it feels like, what we're observing is that we're at the cusp of potentially over the next couple of years, some really transformative gains in the context of how well we do at keeping people happy, healthy, and out of the hospital. We have to stabilize through the headwinds that we're in at this moment. But if we can get through that, I think there's some sunny days ahead.
And certainly that's what we've seen, right, with the 70% of respondents saying they expect this to grow in the next 24 months, right? There's still a lot of confidence that we're sort of at the precipice of even another bigger jump in these models. But let's key off of something that Kristie was talking about a little bit earlier in terms of meeting providers where they are. So let's talk a little bit about how you do that, right? How do you meet them when they're at different stages of readiness? And how do you assess their readiness to move to risk and move to these more advanced payment models? So Kristie, you want to start with that one since you brought up the provider readiness?
Yeah, absolutely. This is such an important question as well. At Elevance, we really look to take a staged support first approach. What we've learned in our over a decade of doing value-based care, contract structure alone will not change care delivery. Providers need clear goals. They need incentives that are aligned to clinical decisions that they can influence, and then that support along the way that can help them operate differently. So we at Elevance, we start with a readiness assessment where we're looking with the provider at data capabilities, care management, financial operations, and then pairing targeted enablement with graduated contract design. And it really is not a one size fits all. We see that based on provider archetype, some providers are really, really well suited for downside risk. And we find that downside risk is most effective where providers have real control, care coordination, chronic disease management, preventive care, and proactive outreach to high-risk populations. But for Elevance, downside risk isn't our goal. We see downside risk as a tool, and we're very much focused on what is the right tool to drive the outcome, which is creating better outcomes, better experience, and better cost for the members that we serve. And so progress really depends on meeting providers where they are and using the right lever that's based on providers' readiness.
Let's see, Dr. Calamia, you want to go next?
Sure. So I think I agree with much of the approach that Kristie talked about. Our approach, AmeriHealth Caritas, is very similar. I think it really starts with knowing the practices, right? Knowing, your partners. And so there's a real emphasis that the company has in getting into those practices, getting in with the providers, with various types of providers, and really understanding the flow of the office, as you said, that that kind of architecture in the beginning to really understand, do they have the EHR? Are they already in risk-based contracts? Where are they in that continuum? Are they in the 1 category? Are they in the 4 category with other payers? And understanding a little bit of what they've had successful success-wise or not success-wise. I agree with Kristie, something that she said, which I think is really critical, which is that there's not an end goal always to push everybody to the right. It's really about them being in the right space. It still drives the quality of care that you need for that member. And so it may not be, someone may be in a 3B category, but that's not really where they belong today. And so how do we wrap our arms around that and make sure that we're really giving them that right support so that they are ready to be even where they are? Could be with another provider, could be with another MCO, but really helping them to say, you know what, you should be looking at this. Maybe there's a reason why you're not getting that whole incentive check, because right now what you're trying to do and what you're trying to push through, really you don't have that level of sophistication at this point. Doesn't mean you can't get there. It just means at this point there may be something else that has to mature out, or something within your environment. And Kristie said it very well, which is that sometimes they're not controlling all that total cost of care. And so therefore, are there things that they can shift in their environment so that they're able to do that? Now, we as do Dr. Khan and Kristie also have programs that we can have within our graphs that hopefully can help some of those providers transitions of care program when they come out of a hospital system, for instance, or move into another setting, or a care management program that perhaps is disease specific that really hones in on some of that, and they may be under leveraging some of those tools that we have and that others have throughout their practice. And so therefore, again, that readiness is not quite there because they don't realize that the partnerships they could have with us, also the partnerships that they can have within their own community. Again, because our population is highly Medicaid based, there are a lot of SDOH programs and other community based organizations that can be very helpful to our practices. They may not be leveraging those today the way that they could be leveraging them. So can we help to bridge and build that for them? So again, they're able to move across that continuum comfortably and get to that better value-based care. So for us, that approach that Kristie discussed is very similar. And those components would kind of go into that, right? Are they leveraging, everything that they have within their community? Do they have that control, that control of total cost of care because they have a close relationship with the hospital system, or they have close relationships with subspecialists, et cetera, where they're able to really, again, drive that value. So part of that readiness is really in that continuum.
No surprises. Yeah, Danielle, there's probably a lot of agreement, but I think the piece here of knowing your network that Edie pointed out is really critical. I think we've been spending an increasing amount of time over the last 18 months really saying, when we've transitioned from an era where a lot of practices or a lot of systems may have said, no, we're ready for this, right? And let's go further. Now we are at a place, obviously, where people are maybe retrenching, right? So and we want to support that in both directions, but really honestly, getting to know them, understanding their full capability set, and then either meeting them where they are and being like, you know what, it does make sense to devolve back. Let's go back to the future, right? Let's go back into a, pay per quality gap sort of situation, or let's go into something that's a little bit simpler from a risk perspective. But then let's work with you on doing things like the things that we did in the 90s and 2000s, right? The Aetna clinical collaboration program, we are literally putting nurses back at the bedside in hospitals, Yale New Haven being the first and a number across the country, to do nothing more than the discharge planning and being an easy button for our health system partners who are overwhelmed with sending people out or trying to get them discharged or dealing with throughput. And oftentimes then our patients and our members are ending up in maybe suboptimal settings, right? So to Edie's good point, when we partner with the right kind of programs and we say, we are going back to the old tricks of managed care because those worked, right? When we really focus on last mile challenges, that can be helpful. But on the other side, we can also say to people, hey, listen, you actually could do more because, and this is critical, right? I spent 15 years in value-based care on the provider side at Oak Street Health, CareMore Health Plan, and Iora Health before this. It's all about purpose-built operations. And when we see that systems or we see that purpose-built providers have the depth of their own transitional care programs or their own longitudinal care management programs, or they do a really great job of disease management, or they've got a fantastic ground game and they make sure people don't fall through the cracks, we can say to them, listen, you actually have the capabilities that we know from our own evidence, our own internal analyses, will make you succeed in this, right? So let's talk instead about how we make that easier for you. Again, from the utilization management levers, the care management levers, so on and so forth, but we will help stabilize you in this space, and here's how, right? So I think exactly as Kristie put it, supporting in both directions becomes really clear, right? That piece of downside risk and the concentration of downside risk, getting to operational changes is why downside risk is important, but the key is the operational change. And so how we get there, how we incentivize it, that's what's crucial.
Yeah, it's interesting that I think the assumption heretofore has been sort of, move up or out, right? And I think what I'm hearing from you all is maybe we need to be a little more fluid, right? Of, kind of people, changing based on performance and what's available and, what you think you all can provide to help them be successful. So very interesting. So you talked about an easy button. Let's think about this from the public-private alignment perspective. Sometimes it's obviously easier if the models across the payers are a bit more aligned, right? What can we do collectively to achieve this moving forward? And I would say, unfortunately, we aren't able to have CMS on the call today, but think about that not just among the private payers, but also with the public payers. So who wants to start there? Edie, do you want to start?
Sure. I think, listen, CMMI has really helped build that bridge between the public and private sectors. And so I think that, those alignments really will be critical because as we said, it is very difficult sitting in the provider seat when payments and strategies are not aligned, right? Because for you, it's just about the person that you're seeing. It's just about that member, the patient, as Alice said earlier, whether you call them a member, a patient, or person, that's someone sitting in front of you, and you want to get them to a better state of health. And so when you can align those and kind of take that out of the equation, I think that helps as much as possible. You heard Adam speak earlier, Bollinger about Imagine Pediatrics and some of those types of relationships and companies that he's built. And really kind of that private sector really looking at these types of investments and saying, we want to be behind, practices that are willing to really look at, that value-based and give that type of valuable care. Well, I think that disruptors like that, I'll call them disruptors, but, I think that when you have those type of folks in your environment, in your ecosystem, it really kind of raises all boats, right? So that, others will look to that model and say, you know what? We could be doing something along that lines. And I want to be giving as good a care as someone would that they would, kind of walk into an Imagine Pediatrics. And again, the focus is maybe different. We understand practices are going to be in different spaces, but they want to be part of that ecosystem where the care is better. And so I think that alignment really helps tremendously. And those folks within our ecosystems will help to kind of raise that for us. In general, I think again, again speaking from the Medicaid's perspective, states obviously, look at our reimbursement through a HEDIS lens and through quality lenses. If those, can really be aligned as much as possible, again, to get those best outcomes, and those incentives can be aligned, that will help all of us. That'll help, Ollie, Kristie, and I sit down and basically say, hey, you know what? These can look very similar because, again, our incentives are all aligned. And so we'll understand that this is what value looks like. And so really kind of hitting on those key elements so that we can kind of make that happen across the board, I think will be critical.
Ollie?
I think that's exactly right as a first step. And I think we've got a unique opportunity here, right? As there's new leadership from the non-for-profit side with NCQA and other actors. We've got a lot of activity around what our innovation center model is doing. The fact that LEAD has doubled down, obviously, on the approach from ACO REACH in a simplified set of measures that are mostly clinically relevant and outcomes based is actually huge, right? And so the more that we can see that sort of discrete alignment between the complex array of Medicaid quality measures that vary from state to state, and then the measures that each of us as a health plan on the MA side emphasize that sometimes can differ into what we see in the lagging tail of commercial across the board. The more that we are getting that kind of conversation around the next generation of the quality industrial complex in this country has to be very streamlined to make this serve the members whose lives we are attempting to improve, and to make it easier for providers to actually process this, I think is a huge opportunity. But Danielle, I'd say the other one, and I think where I've seen a lot of excitement for us on the Aetna side, is really in how, in a world in which we spent the last 10, 15 years, obviously focusing heavily on primary care as the locus point for control and potential improvement, now, or how are we really investing from a specialty perspective in terms of driving meaningful outcomes improvement and alignment? And so I think the more that we see the next generations of, the oncology care models and OPM and the like, the more that we see a lot of the things that came out in the last 5 years from CMS and the Innovation Center mirroring what we are doing in the private sector around, specialty-based care models and CKD and MSK and cardiology and end of life and so forth. Again, that hits the critical mass that incentivizes providers to actually put in the infrastructure to go forward, right? And when we know that, and I say this as a practicing primary care physician, when we know primary care continues to be at a breaking point, we have to find other places to offset or just to let out some steam. And specialty may be a really important place here, particularly oncology, given the pressures on both total cost of care and RX spend.
Kristie.
Yeah, Dr. Khan and Dr. Calamia, really, really great points. At the risk of saying the exact same things that you did, I'll just build off of a couple of your points. So first, I think that one of our biggest opportunities is really around aligning on quality measure definitions. And I know we've been trying to do this for years, and it continues to be a challenge. Having been for a big chunk of my career on the provider side, there's nothing more frustrating than every plan coming to you with a different set of metrics and a different way to measure them. So I still think that there's a lot of opportunity to align there. And then Dr. Khan, I think your point is really well taken on specialty. We've spent a lot of time really designing and developing around primary care, and we've made really, really great strides on that. And I think the next frontier is on specialty. That's absolutely an area where Elevance is continuing to innovate as well. And I think that the CMS multi-payer models are really powerful because they do create a common architecture that private sector models can be built on. And when we're aligning, we are able to reduce administrative burden that allows our providers to really focus on improving care. So when those public and private models are aligned, which doesn't mean that they're identical, but building on the same building blocks and the same foundational pieces, then our providers can invest just once, scale faster, and see a clearer return on that transformation.
Yeah, the alignment on quality is something that's certainly near and dear to my heart as the chairperson for the core quality measure collaboratives that all of your organizations participate in. But it's certainly, as you said, Kristie, we still have a lot of work to do in that area. I'm interested if you think that the move towards interoperability will help with this to the extent that we're able to have truly digital measures.
Yeah, I think that has to be a part of our next frontier as we leverage, AI and automation and the ways that can really streamline. And I have a very firm belief that we have to get the data that a provider needs within their workflow, and really that level of interoperability to make it simple for the provider is what it's going to take to get to that next level of success.
Okay, so let's start thinking about the future. We're here to celebrate the 10 years past, but we're going to be at this, I think, for a bit longer. So what does success look like in these models in the future? How is it that we need to evolve? I think, Ali, you mentioned a little bit around specialty is an important new area. Maybe you can start us off.
Happy to, Danielle. And I would say, I think, at the risk of starting to sound like a broken record, I do think this is exactly the issue of where are the other places that are complementary for us to dive deep on, right? I think specialty care and then transitions of care are honestly two places that we can all acknowledge we haven't gotten right yet, but they're also durable problems, right? Members and patients fall through the cracks in those spaces over and over again. There is a chance to partner deeply with systems to get this right, particularly as they are thinking about are they moving back, are they moving forward, right? How can we bring the kind of tools, to Edie's point, the kind of programs that we have already to amplify what they're doing and to shift from the often adversarial position that we're in to one of actual partnership is a huge opportunity here, right? This is a space where the winners that we are seeing, especially in the specialty VBC space, but also in transition care, are not focusing on utilization management or focusing on formulary changes or focusing on financial levers or benefit design. They may be doing some of those things, but they are focusing heavily on longitudinal proactive care management, right? Which is the reason that probably all of us went into this business to begin with, but which in an era of tons of different other demands and checklists have has often fallen by the wayside in the face of regulatory pressures or other demands, right? And so the chance to see that we are putting our own members into models where they are getting that kind of like day-to-day support that we'd want for our parents and grandparents, and that's going to 40, 50, 60% of our population, not 3%, 4%, or 6%, whatever we're funded for oftentimes. That's where I think there's a lot of opportunity and a lot of excitement. We're seeing that with some of our partners around the country today, and we're eager to keep leaning in and figure out how we continue to push that forward through the kind of care model approach that we take to maximize the levers that we do have to help them go faster.
Kristie?
Yeah, I think just building off of a few of the other comments. So I think that one, we're starting in a good place. We are able to demonstrate that value-based care is working. And our data consistently shows that it's improving cost and it's improving quality. But participation alone isn't the end goal. So I think that the next phase, as we think about, I'll break it out into kind of primary and specialty. The next phase for primary care is getting even more targeted. We have to be looking at what are the measures that clinicians can actually influence in their day-to-day work, ensuring that our risk models are matched to provider capabilities, making sure that we have real-time actionable insights, ideally within the provider workflow, and that the tools are practical and can support day-to-day care delivery. So what you're hearing is, let's make this simple for providers, that this is available to them within their workflows. This isn't an additional thing. Becomes how they work. And the way to do that is to make this simple for them. So good strides. I think that there is more we can do there. And then to the points that Dr. Khan is making, I think our next frontier is really how do we take these principles and thoughtfully apply them into specialty care and into pharmacy space. So I think over the next coming years, we're really going to see some good innovation in that space, and it'll be learning just as we have, throughout the past years that's been primarily focused on primary care. So I'm excited to be on that journey. And I think our signal of success, when we will know that this is working and that we're on the right path, is when providers choose to deepen their participation with us over time, because the models are working for them from a financial and operational standpoint. And more importantly, the models are working for their patients, our members, and that we truly are continuing to produce better outcomes and better cost.
Edie, you get the last minute.
Wow, it's a tough one because I'll tell you, it's tough to go last in the sense that I think Dr. Khan and Kristie really put this beautifully already. I agree with Dr. Khan. It's really about the partnerships. He spoke about those partnerships and deepening the partnerships again. The real-time and actionable data that we spoke about earlier and maturing that out. I think that's what success looks like continuously. To me, I agree with Kristie. There is a bit of a separate approach in the sense of what we can expect from our PCPs and those overburdened PCPs, and then how much that they can control, and how do we then work with the larger ecosystem to pull them into the same types of conversations and really define very clearly what the outcomes need to be. Again, that's, I think, something that the MCOs can really help out there with to give that level playing field, because as a payer, we are the one that interacts with all of those different parts of the ecosystem indirectly. And so sharing that type of data with them, I think, is important. I love something that Dr. Khan talked about earlier, which is the places where we have the spend, MSK, end of life care, really understanding where that spend is and where some of that needless spend is. I guess as a geriatrician and someone who, specializes in palliative medicine, this is really kind of near and dear to me. But, we have so much spend that occurs that really is needless spend, and so at that end of life, and so really understanding that piece of it and trying to engage our providers and having conversations with our members earlier, and again seeing that as part of the value proposition, right? It was oftentimes kind of thought about really as kind of a dirty word you don't talk about is end of life, and we need to be very positive about our members, but sometimes some of those transitions at that end of life is something that families want and need, and so I think addressing those those things and supporting again our providers and being able to do so through programs that we may have or programs that they can leverage within the community. So I think, again, understanding where this spend is, in gene therapy, paying for outcomes. This, I think, is really a great, this was a great, advancement forward, because we know these are very expensive therapies, but they may not be for everyone. And you may not be set up for success to go through that. And so, having spent some time on the provider side, I've watched patients, being able to kind of go through those transitions and not be successful, or not understand, maybe some of, what could be deleterious outcomes. And so really making sure that our members and our patients are cognizant of what they're getting into. And then again, enabling our providers to get them the best outcome and to really pay for quality in that space. It becomes critical. Yes, it's very expensive, so we should be paying for the best outcome possible. And maybe that means investing in a little bit more of an infrastructure in order to support patients through those transitions, and that then becomes part of that value proposition. So again, I think my co-panelists put it very well already. There's not a whole lot to add after that, but again, I think that's what our measure of success will really look like: empowering the providers.
Well, that's a great note to end on. Thank you so much, Dr. Calamia, Dr. Khan, and Ms. Spencer, for sharing your expertise